Hello, good morning. This is your discussion or continuation of our discussion on musculoskeletal trauma. Still, we are talking about fractures, and this time we'll be talking about the bone healing process. So, in our bone healing process, okay, you have your inflammatory, reparative, and then remodeling phase. The three phases of your bone healing process. Depending on the extent of injury, your bone healing process may take up to years, okay, until the bone will be able to restore its normal function. So what happens? On the first part, what you refer to as your inflammatory phase, there will be inflammation. This inflammation is brought about by this process. First, there will be necrosis of the osteocytes. Okay, this necrosis of your osteocytes is related to the inflammation, bleeding, and hematoma. Okay, because of the injury that your patient would had, damage to the bone would lead to the necrosis of the osteocytes. Then you will have the inflammatory processes. So the inflammatory processes would involve your vasodilation and then your edema. Our body has a reason why we are having vasodilation. The purpose of vasodilation is to cause the migration of your fibroblast. In other words, it is dilating to supply the necessary elements, the necessary chemicals, the necessary transmitters to elicit the healing process. Okay, but of course on our part that will be resulting to pain. Okay, so it happens. Once the vasodilation would occur, there will be enlargement of the blood vessels. This enlargement of the blood vessels would lead to the migration of your fibroblasts, lymphocytes, macrophages, and osteoblasts to the sites. Okay, so you have these cells, fibroblasts, lymphocytes, macrophages, and osteoblasts going to the site of infection. So what will be the purpose of it? Your fibroblast class will be able to promote growth of granulation tissue and then the capillary buds. Your lymphocyte and macrophages will wall off the area. Okay, they would localize and try to contain the inflammation. Other than that, okay, your macrophages will be able also to respond to infection. Okay, the risk for infection. Then later on, there will be your capillary buds, which will supply nutrient to promote the formation of the collagen, and then later on would allow calcium deposition. So remember, it is the collagen that would act as the matrix of the bone, where your calcium will be depositing. So that's what happens during your inflammatory phase. There is inflammation, and this inflammation is brought about by vasodilation. And due to the inflammation, it results to the migration of your fibroblasts, lymphocytes, macrophages, and osteoblasts. Then you have your reparative phase. During the reparative phase, the following occurs. There will be what we refer to as your callus formation. Okay, the osteoblast would promote new bone formation, and then the osteoclast would destroy the dead bone. Okay, reparative phase. So what happens is that repair begins. Okay, callus is already formed. Then you have your osteoblast. Okay, remember the role of your osteoblast. It would try to promote new bone formation. And then osteoclast, okay, would try to destroy the dead bone that your body would have. Then you have your collagen. The collagen would be formed and your calcium would start to deposit. Then you have your remodeling phase. In the remodeling phase, there is already removal of the excess callus. Then there will be new bone calcification. Then there will be reuniting of the bone. So the main purpose here of the orthopedic surgeon is that before the remodeling phase, okay, even before the onset of your inflammatory phase, okay, the doctor should be able to align the bone properly. Because if not, okay, the bone will keep on growing and then in the wrong direction, and then the tendency is that there is what we refer to as your malunion, okay, or in other words, misalignment of the new bone growth. So again, I hope you can recall the process of bone healing. So you have your inflammatory, then you have your reparative, and then the last one is remodeling. So what are the factors influencing bone healing? Okay, age. Okay, so age, the higher the age, the higher the age, the longer, okay, the bone healing process take place. Physical condition. If your patient would have complications related to the fracture or even comorbidities, the healing process would be longer. The more complicated the fracture is, the longer the healing process will be. Then you have the factors influencing your bone healing. One, immobilization. Okay, remember that one of the emergency management for your fracture is the immediate immobilization of the site of injury. Okay, so when we talk about immobilization, that may be with the use of your splinting. Later on, that will be with the use of your traction. Okay, later on, you will see that there will be pins and screws that will be used for the management of fracture. So, immobilization is the key in the management of your fracture. Okay, so class, oftentimes when we do the immobilization, especially if we're talking about fracture of the bone, what is being immobilized is the joint above and the joint below your bone. Next, timely correction of displacement. Okay, timely correction of displacement. Then you should have the application of ice. So the application class of ice will be able to reduce the inflammatory process, especially on the first day of your injury. Then you have adequate amount of growth hormone, vitamin D, and calcium, which are all crucial for bone growth. Adequate blood supply, which will be able to supply your fibroblast, which is part of the reparative process. Then class, there are procedures also referred to as electrical stimulation that would stimulate bone growth. Then absence of infection. Once your patient would have osteomyelitis, the bone growth or the bone repair would be very slow because it would not be able to process. Osteoblasts will not be able to deposit once there is deposits of pus. That's why we always give prophylactic antibiotics, especially if we are dealing with a patient class, especially with a patient with open fracture. Then the higher the age, the poorer the recovery. And then if your patient had moderate activity level prior to injury, the chances of having the bone repair is higher. Okay, why? Remember that the bone repair would facilitate bone growth and bone mass, okay, which would mean that the bone mass would be having sufficient supply of collagen and then also your calcium. Okay, so activity prior to the injury would help on the recovery. You have several complications for fracture. Let's try to tackle them. Okay, 1. Acute compartment syndrome. So when I talk about acute compartment syndrome, this is characterized by increase of pressure within one or more compartment. Okay, so class, when I talk about compartments, our muscles are actually made of compartments. So look at this cross-section of the leg. There are several compartments that can be seen. Okay, so in acute compartment syndrome, what happens is that there is inflammation. And this inflammation class is actually caused by the swelling of the muscles because remember there is injury. Once there is injury, inflammation is anticipated, expected. In this case, the inflammation occurred on the compartment, okay, of your muscles. Okay, muscle compartment. Now, what's the danger here? It reduces the circulation in the area. The common sites of your compartment would be your lower leg and your forearm. And your acute compartment syndrome may result from improperly fitted cast. Okay, the cast which is used for the management or immobilization. Then bleeding or edema within the structure enclosed by the cast. And your acute compartment syndrome would usually develop on the first 2 days of injury. So, what are the signs and symptoms of your compartment syndrome or our problem here in compartment syndrome? There is increased pressure in the compartment. That's the big deal here. This increased pressure class leads to entrapment of nerve, blood vessels, and muscles. Nerve and blood vessels, crucial. That would lead to decreased tissue perfusion. And because of the decreased tissue perfusion, cellular acidosis would occur. And because of the occurrence of your cellular acidosis, dilation of capillaries and leakage of plasma proteins would occur. With that, edema will occur. Okay, remember, proteins. And with edema, there will be further compression. And if there's an access for the bacteria, sepsis could possibly occur. Your ACS, if not managed promptly, can result to possible loss of limb. Okay, so that's why we always monitor for the signs of ACS. Recall the 6 P's that we have been talking about, okay, in your neurovascular assessment. Class, the 6 P's could be a sign of your acute compartment syndrome already. Okay, or oftentimes other textbook would say this is pain that is not relieved by the pain medications. Okay, pain that is not relieved by the usual pain medications. Okay, so the 6 P's are actually early signs of your ACS. Your pain, pressure, paresthesia, pallor, pulselessness, then you can add your paralysis. Okay, now, on the late manifestation, You would have cyanosis, your tingling, the loss of sensation, severe pain, and renal failure. That's why for cases like this, okay, if you're dealing with fracture, you need to watch out for acute coronary syndrome. And your acute coronary syndrome class is already considered to be, okay, your acute coronary syndrome is already considered to be an emergency. Okay, this sequelae or complication is already an emergency. Then you have your Volkmann's contracture. Okay, class, your Volkmann's contracture, as shown in the picture here, okay, this is actually a permanent flexion contracture. Look at it, it's a flexion position of the hand and wrist, like a claw deformity of the hand and fingers. Okay, so it results from the passive extension of fingers, which is restricted and painful. Okay, so what do you mean by that? There is flexion, and then once you will be extending the fingers of your patient, it will result to pain. Okay, this is because of the lack of blood flow or ischemia to the forearm that occurs when there is increased pressure due to the swelling, okay, such as your compartment syndrome. So that's your Volkmann's contracture, okay, a part or complication still of your compartment syndrome. Because of the absence of blood supply going towards the distal end of the extremity, the tendency is that the muscle will be on flexion. Okay, the muscle will be on flexion because your extensors are not able to maintain their function due also to the decrease of the blood supply. Okay, take note, class, that your muscles would have two. There are flexors and extensors. Okay, so what is our management for acute compartment syndrome? Still immobilization, application of ice to reduce inflammation, and then elevation of your injured extremity. Okay? Medical management. So class, the oftentimes cause of this is too tight cast or no, improperly fitted cast. So what is being done? Okay, so removal of the tight fitting cast. Bivalving of the cast may also be done. Okay, so class, when I say bivalving, okay, you are cutting part of the cast to reduce the pressure brought about by the cast. And then another management that could be done is what we refer to as your fasciotomy. Okay, so this is an example of your fasciotomy, a cut done to your muscles. So class, for your fasciotomy, okay, your fasciotomy is a cut through the muscle. The purpose, class, again, is to release inflammation and to relieve pressure. Class, the fasciotomy may be left open even up to 2 weeks until the inflammation would resolve. Okay, if the wound would not be possibly closed in 2 weeks because of the inflammatory process, well, there's a possibility that the skin graft would be applied. So when I say skin graft, part of the skin will be taken from other part of the body to cover here. Okay, it's just like a flap of skin. Then you have the term crash syndrome. Class, your crash syndrome would occur from an external crash injury that would compress one or more compartment in the leg, arm, and pelvis. Again, it involves one or more compartment in the leg, arms, and pelvis. Okay, so this is a life-threatening complication of your fracture. What are the specific causes? So it could be the twisting type of injury. Now, when I talk about your crash syndrome class is indicated by the following. So you have your acute compartment syndrome. You have signs and symptoms of hypovolemia. So your patient would appear to be dehydrated. Later on, we will know that it's because of fluid shifting. Then you have your hyperkalemia. So recall that your potassium is an intracellular fluid, or intracellular electrolyte, I mean. So class, for that reason, during your crash injury, if there is severe damage to the cells and if there is necrosis of the cells, the tendency is that your potassium, which is from the inside of the cell, would be going out, okay, resulting to your hyperkalemia. Class, your rhabdomyolysis is due to the rapid destruction of your muscle tissue. Okay, again, rhabdomyolysis is secondary to the rapid destruction of your tissue or muscle tissue. Okay, which is also considered to be life-threatening. So class, when I talk about rhabdomyolysis, it's actually part of the muscle being distributed or being released to the bloodstream. This rhabdomyolysis could possibly cause your acute tubular necrosis. So when I talk about acute tubular necrosis, that would mean damage to the kidney or acute kidney injury brought about by your rhabdomyolysis. So once the substances from our muscles would be released in the bloodstream, their tendency is that to go to the kidney to be released. Okay, these substances has the tendency to clog up the kidney, leading towards necrosis, and your patient will experience acute kidney injury, sudden increase in the values of creatinine, sudden recurrence of edema, kay class or anasarca, generalized edema due to the failure already of the kidney. If not managed, okay, the effects may be irreversible, and your patient may need to be placed on dialysis. Then you have your muscle weakness and pain. So mentioning these complications to you would already imply that this is a life-threatening condition and should be managed promptly. So hyperkalemia, you need to have it corrected. Hypovolemia, you need to give your patients fluid in consideration to the cause that your hypovolemia is related to the third spacing or fluid shifting. Okay, so crash syndrome. So pathogenesis. Class, I derived this from the internet, a good picture or diagram to explain how your crash syndrome would occur. So the pathogenesis or the pathophysiology is your muscle necrosis. Okay, muscle necrosis brought about by prolonged pressure and muscle ischemia. Okay, so that is your affecting to rhabdomyolysis, resulting to third spacing, resulting also to metabolic abnormalities such as your ventricular fibrillation. Recall that your ventricular fibrillation is considered to be a life-threatening dysrhythmia. Then you have also your disseminated intravascular coagulation, which would lead to bleeding. Okay, and then other complications such as your compartment syndrome. The bottom line, this is caused by compartment syndrome that led to muscle necrosis, hence the multisystemic complications and even result to multi-system organ failure. Now, you have your hypovolemic shock. Okay? Class, although it may be difficult for us to treat osteomyelitis because of the effect on the blood supply once your bone is infected, we could not deny the fact that your bone is vascular. There is a risk for bleeding with bone injury, and this may lead to severe blood loss. And early signs would be including your increase of cardiac rate and then the decrease of your blood pressure. So recall, in hypovolemic shock, there is an increase in cardiac rate because your body is still trying to compensate. However, the blood pressure is decreased. Later on, class, again, the pulse will be decreased. Okay, later, the pulse will be decreased, weak, and faint. Then, you have your septic shock. So, class, septic shock resulting to systemic vasodilation due to the presence of bacteria. Okay, so obviously, it's considered to be a life-threatening complication. So, what is our management for shock? Since we're talking about shock, there should be administration of your isotonic solution. Blood transfusion is done due to the blood loss, and then bleeding should be adequately controlled. And then there should be administration of your antibiotics. So class, for your antibiotics, the administration should be systemic antibiotics, and oftentimes they are using multiple antibiotics to make sure that the patient will be managed, especially if your patient is already confirmed to have your sepsis. Okay, but class, if as a prophylaxis, they are usually using one antibiotic. Okay, but once with sepsis, you'll be using combination of antibiotics. Next, fat embolism syndrome. So class, your fat embolism syndrome is related to the globules which are released from your yellow marrow into the bloodstream. It may occur 12 to 48 hours after an injury. So what are the signs and symptoms? Your patient would have confusion, altered level of consciousness. Why? What happened? The fat emboli could have clogged up to the brain. There is tachypnea, dyspnea, hypoxia. That happens if the emboli would clog up to your respiratory blood vessels, such as, for example, your pulmonary artery and your pulmonary artery. Then you have your renal failure. That is, if your emboli would be going towards your kidney, resulting towards your acute kidney injury, your oliguria, and anuria. There will be presence of petechiae in the skin and buccal mucosa, and then conjunctival sacs and fundus. Okay, especially class, if the clot, or the emboli, will be clogging up on your conjunctiva or your eyes. So fat embolism syndrome is considered to be a life-threatening complication also. especially that you have a possibility that this could clog up, or the emboli could clog up on the microvasculature of your vital organs. One particular example of which is your heart and then your brain. So, what is our management? Focus supposedly is prevention. So, what do you mean by prevention? Okay, you need to immobilize and stabilize quickly. There should be rapid replacement and control of bleeding. You should monitor for changes in the level of consciousness. And then for the respiratory support, oxygen therapy, and ventilatory support. Okay? Plus, usually your fat emboli syndrome. Okay, your fat emboli syndrome would lead to life-threatening complications with poor prognosis. Okay, so for that reason, prevention is really our focus. Okay, because once it would occur, it would be already difficult to manage / treat your patient. Then you have your venous thromboembolism. Class, the venous thromboembolism is related to deep vein thrombosis, and it could be pulmonary embolism. Okay, what's the cause here? In fracture, I need my patient to be immobilized. However, one complication of your immobilization is deep vein thrombosis and pulmonary embolism. Okay, so deep vein thrombosis deposits of clot. Okay, whereas pulmonary embolism, the traveling of your clot towards your pulmonary artery and pulmonary vasculature. So this is a result of your venous stasis or blood flow, injury to the blood vessel wall, and altered blood coagulation. So still, life-threatening. So what do? Okay, we assess for the following: presence of swollen or swelling, pain, tenderness, cramps, and then your positive Homan sign. So remember, your Homan sign, okay, is positive during the Homan sign positive is the presence of pain during the dorsiflexion of your ankle. In other words, this part of your foot will be pulled towards the body, okay, or will be pushed towards the body. Once there is presence of calf pain, you would suspect venous thromboembolism. However, Homan sign has a low sensitivity and specificity. It does not mean that if your Homan sign is positive, it would really be right away venous thrombo or venous or deep vein thrombosis. Deep vein thrombosis. Okay, again, I hope that you have realized the difference between deep vein thrombosis and then your venous thromboembolism. So, when I talk about your deep vein thrombosis, your deep vein thrombosis class is only related to the formation of the clot. But once the clot would travel to other parts of the body, that is already referred to as thromboemboli. So what is our management? Your patient should be maintained on complete bed rest for 5 to 7 days. Okay, thrombolytic therapy if there is no risk for bleeding on the other parts of the body. Then your heparin. Your heparin here, class, would actually act as a prophylaxis. Okay, especially your low molecular weight heparin, such as your enoxaparin. Then you will have your thrombectomy, or the removal of your thrombus. Okay, thrombectomy is the terminology for that. And then what are our nursing management? So nursing management is inclined on prevention. Okay, that would include early ambulation, immobilization of the fractured extremity. Okay, so you need to immobilize, splint, or cast, and then elevate above the level of the heart, administer heparin as prophylaxis, and then the use of your anti-embolic stockings or compression boots. Okay, the purpose of your anti-embolic stockings is to increase the return, okay, to the heart of your blood, and then to prevent venous stasis, hence preventing your clot formation. Another complication is your infection. Okay, the most common type of infection resulting from an orthopedic trauma, okay, is your osteomyelitis. That is your osteomyelitis. So most common, especially for dealing with your open fracture in which the skin integrity is lost and after the fracture has been repaired. Okay, that's why we often salute orthopedic surgeons who are able to do this or able to do the surgery fast. Okay, because if they're able to do the surgery fast, the exposure of the patient when it comes to pathogens would be minimal. Okay, but still they are giving your prophylactic antibiotics. Now, on the succeeding topic, we'll be talking about your chronic complications and then the management for your fracture. Thanks for your attention.